Hello, I just came out of the OR. I haven't finished up my last touch of my slides, but I would just go ahead and start. Yeah, for those of you who doesn't know me, my name is Do-Yeon Cho. I'm a chief resident here, and it's my great honor and privilege to be able to speak about my research and a little about cystic fibrosis tonight. So let's start. So I'm going to talk mostly about cystic fibrosis. It's based on the new therapies. But I just wanted to make a little bit more not boring. So I don't want to talk more about research. I was thinking about the new therapies just came out of the CF society. So it's very exciting. So I think it's going to be also helpful to our society. So we're going to talk about that. And I don't have any financial disclosure. And so this is 5 parts. First, I'm going to briefly introduce what the cystic fibrosis is. Maybe a lot of people know about it. And also, secondly, I'm going to talk about a little about classification of cystic fibrosis, CFTR mutation. So now the classification is very important because the treatment is totally different based on their classification of mutation. And thirdly, I'm going to little touch about what's chronic rhinosinusitis and the cystic fibrosis. And with continuation with that, I'm going to talk about my research, mostly about CFTR function and its antimicrobial activity. And lastly, I'm going to talk about my future research interest. So what's the cystic fibrosis? So I think that a lot of people know what the cystic fibrosis is. It's a genetic disease, a lot of mucus, and it's born with a disease. And there are a lot of lung infections, sinusitis, and also probably some patients had lung transplant. So to summarize this, let's listen to the Liam story, and let's figure out what's his mutation classification would be.
I'm Liam. I'm 10 years old. I have cystic fibrosis. I have to do treatments every day so I can breathe okay.
Tell them what kind of treatments you do, Liam.
I use a nebulizer every day. I forget what it's called.
It's called Dornase Alpha, and it breaks up the sticky stuff in your lungs. What else do you do every day?
I have to wear a vest every day for half an hour in the mornings and before bed to get the stuff out of my lungs. Sometimes when they catch another bug at the doctor's office, I have to use another neb.
He goes to the clinic every other month where they give him a throat culture. The doctor calls it the catch of the day.
I don't like going to the clinic. My throat always hurts afterwards, and I have to take more medicines.
When the culture is positive, they give him tobramycin, which happens most times we go. The doctor says we should probably use antibiotics every other month to make sure Liam stays healthy. We're going to talk about the different kinds of antibiotics we could use at the next visit. Liam, do you remember when you were diagnosed with cystic fibrosis?
No, I was a baby, but I do remember I had surgery when I was born.
That's right. You had what they called meconium ileus, but that was the last time you were in the hospital.
Yeah. A couple years ago, I got paid to go to the doctor's office, and I took blue pills every day.
He was enrolled in a research study for a new medication.
I think I got a lot better then. The blue pills helped open doors.
That's how the doctors explained how the medication worked. And it helps people with your form of CF mutation, which makes protein that doesn't work at all, even though it goes to the right place in the cell. It's the same type of disease your cousin Sean in Ireland has.
I wish we could visit there again. Last time we went, I got to ride a horse.
Okay. So this is 10-year-old boy. To summarize his story, he's 10 years old. Likely he's been diagnosed with cystic fibrosis when he was born, likely from the surgery, meconium ileus. And he also has multiple lung infections, probably like every other month, and requires antibiotic treatment. Sounds like his lung infection doesn't appear to be that bad, requires hospitalization. He said his only hospitalization was when he had a surgery. And he recently took a blue pill, and then it actually got better. And he also likely the Irish descendant. So these are the clues of what the patient's mutation classification will be. I'm going to go over in a bit. So cystic fibrosis, as we all know, like Liam said, is all patients have very tenacious sticky mucus. This is the picture of a lung with a 15-year-old girl who actually underwent a lung transplant here in Stanford. And this is the paper was published by Dr. Jeffrey Wine. And he says that there are a lot of mucus in the cystic fibrosis that's very sticky and tenacious. And it's really difficult to clear out. That's why it's causing multiple organ damages. So briefly, CF, it's first described in 1938. Because even though it's before, there was a multiple, some people say this mutation been like 50,000 years ago, because if the person has this mutation, actually those people won't have a cholera. So they won't have any diarrhea, even though they have infected with cholera toxins, because cholera toxin cannot bind to CFTR. So a lot of survival, people still have the mutation because they probably still able to survive to stand mutation because they survived from all those epidemics. So they probably been a long time ago. And it first described in 1938 by the doctor named, I think Dorothy, Anderson. She actually published in the American Journal of Disease of Children. She noticed that the child was died, and this infant was died, and they autopsied the baby, found that there's cyst in pancreas. And when they look at the lungs and intestine, there's tons of fibrosis. That's why they named cystic fibrosis. And it's definitely a genetic disease. It's inherited by autosomal recessive patterns. And mutation in the gene and protein called the CFTR, which is cystic fibrosis transmembrane conductance regulator, just simply it's chloride or ion transporters. And gene is located in chromosome number 7. And if there's abnormal ion transport, it is causing a thick, very, very thick mucus. And it's affecting multiple organs, lung, sinus, pancreas, liver, intestine, and also causing infertility. So, so these are just kind of very summary of cystic fibrosis that we probably know. And for residents, these are 2 key points you have to memorize. This is always in the in-service exam. As CF is autosomal recessive, and gene is located chromosome number 7. And let's look at the function of CFTR. It's the ion channel, but if you look at the animation of this, you probably can feel better what actually chloride channel does in our body. So usually the chloride channel, CFTR ion channel, plays an important role in the maintenance of our fluid and in the mucus. So just like other protein, has been reached the surface after transcription and translation. Under normal circumstances, when there's a functioning pretty well, all these chloride transport develop into the very healthy thin mucus. It's called air surface liquid. So air surface liquid allows cilia to beat very efficiently and also clear the pathogens, the mucus, all the pathogens and the inhalant particles from outside of our body. However, in cystic fibrosis, where there's defective CFTR channel, and also air surface liquid become very dehydrated, so very sticky and thick. So all the particles and then also the pathogens are stuck into the mucus. They're not able to clear out. So these are the cardinal symptoms, cardinal features between the healthy and cystic fibrosis patient. So the CFTR protein is a very complicated protein. It's composed of more than 1,400 amino acids, and it actually have multiple foldings and multiple structures. So after they translate it into a 2D structure in a protein, they need a process called the cellular processing for it to make a 3D structures. If they don't make a 3D structures, then it doesn't reach the cell surface by the quality control mechanism of our cells in the cytoplasm. So one of the most common mutation in cystic fibrosis is what we call the delta F5 mutation, which means the amino acid at the position of 108th position there's a deletion. It's that amino acid is phenylalanine. That's why initial as F. So the phenylalanine deletion at the position of 508. When you have this mutation, even though protein is synthesized, CFTR is synthesized, however, this post-translation folding does not happen. So they have very defective protein, CFTR. It doesn't reach the cell surface. So this is what's the most common cause of CFTR. And so when someone's seeing the CFTR in the UNC, they notice that CFTR is located at the top of the cells in the apical portion. It uses a very luminous immunofluorescent stain, a very nice CFTR channel in these cells. However, a patient with delta F4 mutation, when you look at these cells, there's no CFTR cells. So CFTR One of the most common causes of the CF, it's the CFTR mutation, is delta F508. And the reason is the processing defect in after translation. So, and now people are thinking about classification. I know the classification is sometimes very complicated, but just very easy to memorize because, easy to remember because just pretend that you're the chloride, you're inside of a room and you're trying to get out of the room and think about the CFTR as you pretend there's a door. So there's two kind of classification. First, you can think about there's a quantity, there's a quality problem. So if the quantity means there's the class number 1 is that there's no CFTR. You're in the room, but there's no door, so you can get out of it. That's class number 1. And class number 2 is you're there, you're inside a room, but however, there's a door, but door is so small, so you can't even get out that well. So that's why there's definitely less number of CFTR as a class 2. So delta 508 mutation is class 2 mutation that there's some CFTRs going to reach the cell surface, but most of them are not, degrade in the cytoplasm. And class number 3 and 4 is a less severe type of mutation. And class 3 is you're in the room and there's a door, however, the door is closed shut. So you can't open the door. That's class 3 mutation. There's a door, however, the CFTR channel is not active. So it's an inactive CFTR, for example, the G551D mutation. And class 4 mutation is a structure defect. There's a door, however, the door is not it's broken. So it's a structure defect CFTR. So patients in the class 1 and 2 mutation has more severe symptoms, and class 3 and 4 has less severe symptoms. So these are the classifications of CFTR mutations, but these became a little bit more important these days because every treatment of CF is different based on this classification. And among this classification, people are trying to figure out the CFTR gene was first discovered in 1989, it's very recently in the Science paper. And initially, people were trying to figure out the treatment through the gene therapies. However, they were not very successful trying to do a gene therapy. So starting 2000, people starting to study about small molecule. How can you just correct the CFTR? How can you stimulate CFTR channel? So the first drug which was discovered was to treat the class 3 mutation, or G551D mutation. This is what we actually seen that Liam's has. So the class 3 mutation is the first mutation we actually found a treatment for cystic fibrosis. It's a gating defect mutation, which means, as I told you, it's there's a CFTR is present, but however, it's not active. It's not active. It's more common in Irish descent, so that's why he kind of speaks a lot of Irish. And there's a new treatment came out in 2012 that is called the ivacaftor. It's called a blue pill, and its brand name is Calutico. I have nothing to do with pharmaceutical company, and I just wanted to tell you. And then this is first FDA-approved treatment for the G551D mutation. And this drug is what we call CFTR potentiator. What it means, it activates CFTR channel and increase the flow of chloride, so make all the mucus very non-sticky and very thin. So let's look at the brief summary, brief animation of what the class 3 mutation is and what this drug actually does.
A class 3 mutation such as G551D produces a CFTR protein which is processed properly and reaches the cell surface. However, it is not functional and does not transport chloride. This has a similar effect on mucociliary clearance as seen in class 1 and class 2 mutations. The gating defect found in G551D CFTR protein can be overcome by ivacaftor, leading to increased chloride secretion and clinical benefits.
So I was in this conference. This was November 3rd, 2011, when the New England Journal, NEJM published this phase 3 study about this medication. This is a very sensational for CF Society. So they finally found the first treatment of cystic fibrosis. So what there's Dr. Richard Moses from Stanford is here, and Dr. Steve Rowe is going to be my research mentor at UAB. He's also here. And this study shows that there's an improvement of lung function in 2 weeks, and it's sustained through the 48 weeks. And definitely there's a lung improvement. At the same time, patient doesn't have decreased respiratory symptoms, the improvements weight, and their sweat chloride test was become normal. So one of the patients at the conference was witnessed that her cat usually lick her sweat because it's so salty. But after she's taking this medication, her cat doesn't lick her sweat anymore. So conclusion of all this recent study, I was in the conference last year, and it shows that this is very effective for the G5-1D mutation, and also the avacaftor, this potentiator, also may be effective in treatment other type of CFTR gating mutation, which means CFTR is not functioning that well. And also sweat chloride change may predict the lung function, which means your cat doesn't lick your sweat anymore, which means your lung function is better. So this is a very sensational medication that actually is a new category, not like anti-inflammatory or antihistamine or any kind of antibiotics. It's a new class of medication which actually improve the patient's symptoms. So, however, the G5-1D mutation is only about 4% of all CF. So the rest of the CF patients, or 87% of CF patients, has delta 508 mutation. That's why I initially explained to you. This is the class 2 mutation. It's actually a worse mutation in the patient. So there's two approaches to increase CFTR. So now people thought that two ways. One is CFTR potentiator, as we talk about it. And then another medication is called, the drug is called CFTR corrector. What it does is it corrects the cellular processing of the CFTR. And it actually delivers the CFTR channel into the cell surface in about several hours. This has been shown in the cell studies. And so they even tested with the culture cell with CF cells. If there's no drugs, there's chloride transport is about 5% of normal CFTR. However, if they put the corrector in the cell, and their CFTR function definitely increased. If you put this corrector and the CFTR, they actually increase chloride secretion about like 15 to 20%. And if they put the corrector plus potentiator, and that their chloride secretion is much more increased. So they definitely do have a synergistic effect of using those two medications at the same time as CFTR potentiator and CFTR correctors. So this medication is now on the phase 3 trial of clinical study. Hopefully this will come out likely end of this year, and likely FDA will maybe approve another medication for delta F508 mutation in next year. So here's another class 2 mutation, what it shows in animations that briefly...
The most common CFTR mutation is F508del, which is a class 2 mutation. CFTR protein is produced, however, is not processed properly and does not reach the cell surface. Lack of CFTR at the cell surface means there is no chloride transport out of epithelial cells. In addition, ENaC regulation is lost, resulting in excessive sodium absorption. This leads to dehydrated airway secretions, impaired mucociliary clearance, and chronic bacterial infection. A corrector molecule such as VX809 could potentially facilitate movement of F508del protein to the cell surface. Additional treatment with a potentiator, such as ivacaftor, could then activate these F508del CFTR channels.
Okay, so currently they're doing the phase 3 clinical trials about the dosage and what are the benefits of combining these two medications in the delta F508 patients and see what are the benefits they're going to have. So, and then I'm going to talk a little bit about, before I just, when I'm talking about these medications, I just want to talk whether this medication can apply to chronic rhinosinusitis. So there are a lot of features very similar. There are a lot of phenotypical similarities between a patient with chronic rhinosinusitis with CF and without CF. Definitely there are some different pathophysiology. However, this is a patient with CF and this patient without CF. This is just allergic polyp. This is inflammatory polyps. But you see there's polypoid changes and all the thick mucus. All the phenotypical findings are very similar in those two categories. So CF, chronic rhinosinusitis with CF, patients all have very thick mucus, decreased mucociliary clearance, and also they have biofilms and inflammations. And also patients with CRS and the cystic fibrosis, with or without cystic fibrosis, they definitely have a very similar features. So they share the phenotype with chronic rhinosinusitis and CF with without CF. I think that's why CF is a great model to study about chronic rhinosinusitis in this setting. And the papers shows in 2000 shows that there's mutation, even the patient's not a cystic fibrosis. However, they have a mutation in one of those genes which is responsible CF, they actually may predispose to have chronic rhinosinusitis in general population. And the studies show that there are about 7% of chronic rhinosinusitis patients has CF mutations. But this is just for mutation. But what about what about the CFTR functional defect in these chronic rhinosinusitis patients? So there must be, even though their genes are normal, their CFTR function must be very low. So I did one study in 2009 with when I first came here, and my study shows that I look at the tissue, sinus tissues of human specimens, and I just measure the chloride transport comparing to normal and sinusitis patient, and their chloride transport definitely decreased in patient with rhinosinusitis. This is non-CF patient compared to normal. So it sounds like they definitely do have decreased CFTR-mediated chloride secretion in patients with chronic rhinosinusitis, even though they're not cystic fibrosis. And so there are also studies from the UAB, Dr. Woodward's who show that if you amplify chloride secretion in this chronic rhinosinusitis patient without CF, they may be also we may improve their mucociliary clearance in the chronic rhinosinusitis patient. So, and then by looking at the new medication called the CFTR potentiators and stimulator, this medication, what it does, it increase the chloride secretion in the air surface liquid. At the same time, it actually maintains the mucus volume and height, and also at the same time improves mucociliary clearance, which means you have better mucus circulations. So just like this is just like endogenous sinus rinse. So if you take this medication, you increase your fluids inside of your sinuses. So one of the side effects of this medication is diarrhea, so which makes sense because it activates all the water flow in your body. So it actually increases your fluid inside of your mucus. So this is more of a Neomed in your sinus medication. And the company is currently not very interested in studying into chronic rhinosinusitis. They really first focus on the CF patients. So none of the clinical studies performed, but I think this medication could be a new kind of area to be investigated in the next few years, that what's going to affect into the chronic rhinosinusitis patients, improving mucociliary clearance by activating the CFTR channel. So
you got chronic constipation.
Right. Yeah, exactly. Right. So
Looking for markets.
yeah, maybe we probably can use it as a stool softener.
Improvements to the stool game.
Right. So yeah. But these are the kind of a current trend. What's the CF Foundation and CF research going on? They're trying to find the small molecules which actually correct. People in the UK doing a lot of gene therapies, but in the US mostly trying to find a small molecule drug discovery, and also trying to figure. This is only about 30% of CF that's been researched. So there are about 70 or 80% of research. There more has to be done for these areas. But my research, I'm going to talk a little briefly about my research interest. My research interest, I think the CFTR is not only for chloride secretions. They're probably more than just one ion transport through the channel that actually cause all those effects. So I think it's more of an CFTR may be related to the antimicrobial activity, may kill the bugs and germs. So my model is that there's a little complicated, but the CFTR and deoxin proton channel model. And one thing is that our epithelial cell has NADPH oxidase. What is NADPH oxidase is? This is just like the neutrophils. Airway epithelium has their own enzyme to protect their cells. So if you don't take, even if you don't take antibiotics, they kill the bugs by yourself. They protect all the pathogens. Just like neutrophils, they also had a counterpart of these killers. It's called the lactoperoxidase and NADPH oxidase in their epithelium. So this is what the epithelium has. And and at the same time, the CFTR channel and proton channel, they work together and balance the pH in your mucus. Your mucus pH is so acidic, and then what they do, if mucus pH is so acidic, then they secrete bicarbonate through the CFTR channel. And if your mucus is so alkaline, pH is above 7.4, and they activate proton channel, increase more proton in the mucus. So actually, they actually work together to balance your pH in your mucus. So once again, if your pH is very acidic, and that they activate CFTR channel, and they actually transport bicarbonate, so make it very alkaline. And if your pH is very alkaline, you actually activate proton channels and increase protons, so actually make it very acidic. So actually they work together just like to make a very mucus balance pretty well. And another thing is they work together as NADPH oxidase. So in normal conditions, the CFTR channel transport chloride, but also it transport bicarbonate. By doing that, the airway pH is very alkalized, and by using the NADPH oxidase, it produces proton through the NADPH oxidase, and then this proton is secreted through these proton channels. And once it's secreted, once the proton is secreted in the mucus, and then it combines with this superoxide, and it forms hydrogen peroxide in the mucus. So this hydrogen peroxide combined with lactoperoxidase, and it actually creates a very super bleach. It's like there's a hydrosteocyanide is a very strong bleach, and this bleach agent can kill all those bugs. So actually those can kill the bugs. And then so my study shows that Dr. Fisher and I studied that patients with control and CF patient, their pH is so low, they're very acidic. CF patients very low pH. And using my sinus tissues, definitely the CF sinus tissue is very low pH. They're very acidic in their nose, not because they increase more acid secretion. The reason they're very acidic is they decrease base secretion. They cannot produce bicarbonate for CFTR. Their airway is so acidic. So that's why we hardly see fungus ball in CF patient. They do have an allergic fungal sinusitis, but CF patients really difficult to see fungus ball because their pH is so low that fungus cannot grow in their sinuses. So this is very related to the pH. And then when we measure the hydrogen peroxide level in these CF patients, their hydrogen peroxide level, which is able to kill the bugs, is very low compared to other inflammatory disease in other normal patient. So when you're adding up, this in CF model, the CFTR is not working, and which means we cannot secrete the chloride, but also we cannot secrete the bicarbonate. So your mucus is very acidic. At the same time, you cannot even secrete the proton because mucus is so acidic, and you're not able to make hydrogen peroxide, and you're not able to make this super bleach thiocyanide, and you're not able to kill the bugs. And this is our model, and this is our focus on the research currently. And so once again, CFTR conducts bicarbonate into the mucus, and it alkalizes the mucus, and it opens the proton channels, and then the protons also being released, and it's by releasing the proton, they generate hydrogen peroxide, and it kills the bugs. So my theory is that CFTR is required for the killing those bacteria. So if there's no CFTR, you can't even kill the bacteria because pH is all messed up. So the lack of CFTR actually results in a very acidic airway, and also the colonize of the microbacteria, and so we cannot kill those bugs. And these are the studies that I've done since 2008. And recently, there's an Iowa paper published in Nature in 2012. They actually published exactly the same result. They have a very great model called the pig model. They have a pig CF model. There's no mouse model in the cystic fibrosis because CF mouse doesn't have a lung infection and sinus infection. That's really, we don't know why, but they don't have very small lung, small sinus. But they have a pig model in Iowa. And it shows that a Nature paper showed that this pig, bacterial killing is impaired in the CF mucus in these pigs. And the cystic fibrosis and non-cystic fibrosis, they have a similar activities of killing the bugs. However, the CF pig has more acidic, and they're more acid. Once they give more bicarbonate, increase the pH, and they enhance antimicrobial activity. So which means if you change your pH balance, they actually increase, they're able to kill more bugs. So, so this is kind of things very interesting as well. Very similar findings came out from a different group. So, so for the next few years, I probably just want to focus on this area also. So when I go to the Deep South in August, I probably study on what are the characteristics of this pH regulation and also antimicrobial activity is this in the CF and chronic rhinosinusitis patient. At the same time, we want to study about how can we deliver the bicarbonate very efficiently. You can give bicarbonate rinse or gel, but actually just activate once and down. So there's no sustained secretion of bicarbonate in those sinus epithelium or airway epithelium. That's kind of another key to figure out. And then I also interested in what are the other ways of generates hydrogen peroxide in these patients and these tissues. So we're able to fight with the outer pathogens. So, and my research mentor will be Dr. Steve Rowe. He's also MD, clinician scientist. So he also has R01, and he was just gonna mentor my research. And so when I was interviewing for I decided to become a clinician scientist, and I was interviewing the UAB, and I was looking at, there are several factors to be successful as a clinician scientist, that you also have a good questions, but also at the same time, you need to have a great model to study, and you also need a great tool. At the same time, I didn't know, you also you need to have a great mentor. You get a K Awards or career development goals, and definitely also have support and also funding. So everything's really worked out well, and it really makes my decision very easier to able to make, decide to go to the Deep South. And right? So and then and then regarding the tool, so they have a great tool. I haven't worked on that. I think Dr. Oglai worked the OCT here in the ears, but we're doing in the sinus. I'm gonna also work on the OCT model. This is the trying to look at, a lot of people are interested in microanatomy, but not doing the tissue sectioning or like put it into the ice chamber. We want to see very functional microanatomy without disrupting the microcirculation or mucociliary mechanism. So there is one way to doing it. It's called the micron resolution, a micro optical coherence tomography. So you look in the real time of all your cells beating and mucociliary clearance. So Steve Rowe is one of the PIs working with the people in the Boston, the Mass General Hospital, and they're working about this optical OCT in the sinuses and respiratory tissues. So I'm going to mostly work on the sinus tissues, and is there any way we can figure out using this in the real patient, and we can measure patient in real time OCT and measure the mucociliary clearance. How it works is, be honest with you, I don't know exactly what it, to be honest with you. So, but it looks like a very complicated system.
Is it more expensive than Eduardo?
Oh, but it's already there. So it's already there, so they don't care, but it's already there. So,
Much more expensive.
it's already there. So what it does is this amazing result. This is a non-CF, this is normal cells, and this is CF cells. And this is the cilia. You see the cilia is beating, and this is their mucus is producing. You can measure the air surface liquid volumes, and you also like periciliar liquid volumes. You can cellular beat frequencies, and you can also see this is also the timing of the mucociliary clearance. So you can measure all these things. However, in the CF tissues, there's no way of the mucus, there's very dehydration, There are almost no mucus. You can't see any like mucus flowing into it. So I think this is a very great tool to study about a real-time basis about the mucociliary clearance and functions, microanatomy, without disrupting this disrupting the airway epitheliums. And also at the same time, you can also see that this mucus gland, there's a mucus is secreting through this. You definitely can see it through the real time. So this is a piglet trachea, and this is a CFTR. There's a normal, and this is CF pig. And there's a normal pig that actually there's a very nice flow of mucus. However, in the pig without the cystic, with a cystic fibrosis, there's almost like no mucus flowing around the areas. So these are the results that have been shown, but this is a very great tool to study about all these questions, ISM. And before just wrapping up my talk, and I just want to focus on how the research is important in our clinical practice. That in cystic fibrosis, when the Dorothy Anderson first described cystic fibrosis, the life expectancy at that time was less than a year, 0.5 years. That's to be 6 months. And over the past several decades, now their average life expectancy went up to almost 40. It may now become more after they've developed new medications. How would it be possible is actually people trying to find a better treatment by doing the research, and they actually improve the survival of cystic fibrosis. There's a huge improvement between 1980s and 1990s. The reason is for almost 10 years improvements. The reason was that they found the CFTR genes in 1989 that actually make a lot of difference in terms of making a better treatment. When you go to CF Foundation website, they daily update what are the drugs available at this point. Phase 1, Phase 2, Phase 3. And this was not in there last year, but now you see all the CFTR modulation drugs have been there. And also, this is all pretty similar to what we are using in the chronic rhinosinusitis patients. However, they're actually, and now there's new drugs coming up as CFTR modulator, which increase chloride mucociliary clearance. And I think this kind of medication also, it's possible, in my opinion, it may become available in our field in about several years later after several clinical trials. So I think we learn a lot from these patients and also their foundations that for the past several years, it's really tremendous for me to work with here and study about cystic fibrosis and learn a lot of their pathogenesis. There's almost no CF in Korea. There's very rare for Asians, but it's a great tool. It's a great tool. So that's what I'm saying. I haven't met any of these patients. I haven't met any of the studies before. So this is a new area of interest, and it actually really eye-opening, and it actually gave me a lot of strengths and in terms of research, and a lot of it changed my goals in the futures. Okay, thank you so much. Okay.